A patient says, atrial fibrillation hardly affects me. But how much is hardly? Clinicians use the modified scale to make that answer precise. The modified scale is a simple way to describe how atrial fibrillation symptoms affect a patient's daily life. Its logic is similar to a functional class. The higher the class, the greater the limitation of normal activity. It is not a laboratory test or a number from a monitor. Assessment starts with a conversation with the patient. The conversation usually includes palpitations, fatigue, breathlessness, and reduced exercise tolerance. Yet the same arrhythmia can feel very different. One person notices only skipped beats, while another has to stop during an ordinary walk. The clinician therefore asks not only which symptoms are present, but also what the patient has stopped doing because of them. Class 1 means that atrial fibrillation causes no symptoms. With Class 2A, symptoms are present, but they are mild and do not affect normal daily activity. The patient may notice skipped beats or mild fatigue, yet continues usual activities and does not regard the symptoms as a meaningful problem. The most important boundary inside the scale is between 2A and 2B. In both classes, normal activity is formally preserved. With 2B, however, the patient is clearly troubled by symptoms, changing pace, avoiding some exertion, anticipating the next episode, or noticing a lower quality of life. That is why Class 2 was divided into two parts. Class 3 means that symptoms limit normal activity. A person may pause during a familiar walk, reduce the workload, or give up some routine activities. Class 4 means disabling symptoms. Normal activity has to stop because of atrial fibrillation. Imagine two patients with a similar atrial fibrillation recording. The first continues working and walking, but episodes are troubling and lead to constant pulse checking. That is closer to 2B. The second has to stop during an ordinary walk because of breathlessness and weakness, and cancels normal activities. That is closer to Class 3. The final rating follows a clinical assessment of how closely symptoms relate to the arrhythmia. The guidelines specifically warn that symptoms may reflect not only atrial fibrillation itself, but also coexisting conditions. Breathlessness may be worsened by heart failure or lung disease. Weakness may relate to anemia, sleep problems, or medicines. mEHRA is therefore a starting point, not a replacement for clinical investigation of the cause. mEHRA helps record the initial symptom burden, discuss a treatment goal, and then check whether the patient feels better. The score itself does not prescribe an antiarrhythmic drug, cardioversion, or ablation. Strategy depends on the clinical situation, patient preferences, coexisting conditions, and the expected benefit of a specific intervention. It is crucial not to confuse two different assessments. mEHRA describes symptom severity, but it does not calculate stroke risk or decide whether anticoagulation is needed. Even with Class 1, when a person feels nothing, atrial fibrillation may remain clinically important. Thromboembolic risk is assessed separately, and prescribed treatment should not be stopped simply because symptoms are mild. The practical sequence is simple. First, clarify symptoms during suspected episodes of atrial fibrillation. Next, ask whether they interfere with normal activity and whether they trouble the patient. Record the class and repeat the assessment after a treatment change. What matters is not only movement on the scale, but also whether the shared goal set by the clinician and patient has been achieved. Save this scale and subscribe for more clear, evidence-based explanations about atrial fibrillation and its treatment.